So I'll formally welcome you to the latest instalment of our Research Lounge series. Today, we're here to showcase the event Let's Talk COPD Diagnosis. So hopefully everyone's in the right place, if that's what you expected. We've got a fun-packed evening for you. We'll finish no later than 7 o'clock, and I just want to thank everyone again for giving their time today. We'll firstly start off with an introduction to community research that is hopefully posing some of the solutions to hospital-based research, and that will be delivered by one of our community researchers, Jack Squires. Then the most exciting bit of this evening is a live tour of our mobile research unit. So you may not know, because I've got this screen behind me, but we're actually on the mobile research unit right now, and we're hoping to give you a very smooth, streamlined tour of the mobile research unit where it is in Hucknall at the moment. Following that, we will hear from Professor Charlotte Bolton, one of our researchers in respiratory medicine, who is going to talk about one of the studies that's been delivered from the mobile research unit, the COPD CFind study. And then what we really want to do during these events is for our information sharing to act and catalyse really thought-provoking discussions. And we would love to hear from you and your thoughts, and also any questions you have throughout the session. Please do not hesitate to put that in the chat. We also have a Q&A option available if you look at the top of your screens on your laptop, tablet or mobile phone. The Q&A has been enabled, so as you think of them, don't feel like you have to save that till the end of the talk. Please pop any of your thoughts into that, and we will ensure that we come round and ask the questions. So I think that's it from me. Only just a polite reminder, if you could keep yourself on mute when others are speaking, just so we don't get a lot of background noise. It's a lot easier to hear presenters and other people asking questions. I know mistakes happen, so don't worry. I'll probably do it as well, but just to keep that in mind as we go along. So I think that's it from me. That's the boring bit. Now I'm going to introduce Jack Squires. I mentioned one of our community researchers, who is going to talk about the community research team and our mobile research unit. Just to set up Jack's presentation, we know from insights and feedback we've had from patients and also research participants that coming into a hospital setting for a research appointment or research visit can pose some issues practically in regards to parking, travel, and sometimes traveling to a hospital and being in a hospital can feel like you're at the center of a universe. Very busy place, and we know we want to encourage priority of access to our research, and Jack is hopefully now going to demonstrate one of the methods in which we are trying to overcome some of these barriers. So I'm just going to hand over to Jack, and hopefully Liz, if you could share the slides, that'll be fantastic. So I'll swap places.
That was a smooth transition. Yep, so I'm Jack. I am the clinical research team leader for the community team here at Nottingham University Hospitals, which is my actual title behind me. As Kate said, it's quite a newly formed team. It was only started about 4 months back. But we have been working in the community alongside some of our partners from the research networks over the past year on the project that we're doing, mainly on our mobile research unit, which is going to continue into this year. So welcome. This is us. You can see some of the members of the team in front of you. We have a very, very small team still, but we're in the process of growing. You can see 2 of our team, Keba, who's the guy with his thumbs up in the middle there, and Elizabeth, who's very recently joined us last month. We've also had a very new member arrive this month, who's called Patricia, and she's learning the ropes at the moment as well. So we can move on to the next slide, please. Okay, so a very brief background to community research, I suppose, because it's quite new to me as well. I am a nurse by background, so I've worked in the hospitals here for about 20 years. I have worked in the deep dungeons of intensive care. So my home, I guess, throughout my nursing career has been very much sat in a hospital with patients coming to me. Um, we I think I became more aware of some of the problems when I moved into research, particularly inviting lots of people from around Nottingham to come into studies. It was something that was just not possible for a lot of people that I was contacting for various studies, initially in hepatology that I was looking at. And it was interesting to hear some of the reasons why, lots of them to do with work commitments, lots of them to do with travel. And we tried lots of different things to try and make it work for people. So we would often provide taxi transport and tried to work outside normal hours as well. But it was often difficult to get the right staff to be available at the right times as well. So we came across a lot of sort of blocks to some people taking part in research, which we never were very comfortable with. As a global community of researchers, there is a continuing effort to make involvement of the community really core, I think. And that's reflected in some of the documentation that's been coming out over the last, I guess, 10 years at least. We were encouraged by the research networks to improve inclusion and move beyond tried and trusted research sites, which we're trying to put into practice very much as a community team. So the National Institute of Health Research vision is all about collaborating with communities, and every time they refresh their research commitments, it seems to it's becoming more and more really core to the beliefs of the research community. Let's move to the next slide. Thank you. So we don't know what the right fit is for clinical services in the community. We're trying a few things out, I suppose, and we really want as much input from the communities, the public that we meet while we're doing it, to find out whether or not we're meeting the needs of the public. And we'd like to be doing it in more ways than one, I think. So the first biggest change that I noticed, I guess, in NUH was that we suddenly had a mobile research unit, and it was quite a sudden thing. It suddenly arrived on campus and was at City Hospital for a number of months, while we were getting prepared to take it out on the road to do a new study that I hadn't really heard about called CFind at the time. And I knew that the research delivery teams from the network were going to come and help with that. But then was asked to take on more of a sort of managerial responsibility for the unit, which I took over from a lady called Lindsay Craig, who was very instrumental in getting it set up in the early days. And we overcame a lot of problems very quickly, learned how it all worked, managed to get enough people trained, and CFind went on the road, and it's been our bread and butter, I think, for the research, the mobile research unit for a good year or more. So we knew that we wanted to increase access and visibility of research, which we think it certainly helps with. People come and ask us what we're doing, which is exactly what we want. We hope that it's increasing the diversity of the people who take part in research. And we've tried to target some events as well to improve that specifically by going to community events run by different communities around Nottingham. We want to increase research collaboration as well between secondary care and primary care. And we are working very closely now with the integrated care boards, and they are providing a lot of our opportunities within the communities that we visit, which is great. Also, oh, sorry. Okay, we'll get to that. I'll stop rambling. We want to be closer to patients as well and maximise all the opportunities. I think we want a tour, don't we? Shall I hand back to Liz or Kate quickly?
Yeah. You could do introduction, Liz, then we'll get Jack set up for the tour and review. You're just on mute, Liz, sorry.
We're going to have a tour of the mobile research unit now. So Kate and Jack are there in Hucknall on the unit themselves. They've got a camera in place, and they're gonna let you see exactly what we can provide on the mobile research unit and why it's such an integral part of our research in the different communities that we serve. So we'll just wait for them to get set up. I'm just going to have a look at the chat. We've got some comments already and some questions as well. So we'll come to those at the end. Let's see.
I'm ready when you are, I think.
Brilliant. Let's go.
Oh no, I'm not, because we've still got a background. There we go, the big reveal.
Woo.
So this is Hucknall Piggins Croft car park. I'm afraid you're on a flying selfie camera. We tried a few different methods, and the mobile in hand didn't really work. So I'm using a laptop. So I'm afraid you have to see my floating head as well. It's a lovely space that we've been kindly provided with by the council up here, and we don't have to pay anything for that, which is fantastic. Initially, we were using a lot of car parks at various supermarkets. Some of them wanted fees, which we prefer not to pay, obviously, being funded by the taxpayer. We prefer to get what we can by forming good partnerships with the councils and the ICBs. You might be able to hear our generator whirring. We've got our own power supply, so we can literally take it anywhere. We've got hot and cold running water, and the people who built the unit come and regularly service that, so it's always kept clean and ready for use. We have stairs, which at the moment are a bit tricky to get up to, so we are very keen on making sure that we are accessible. We have a coach lift, and we use that fairly regularly for people with mobility issues. One of the earliest bits of feedback that we had was that we needed a doorbell outside because people with mobility issues could not get into the unit. So we've done that straight away. It was something that we didn't initially think of. So coming up into the unit, I'm sorry if it's a bit jerky. Kate is modelling our reception area, which you can't see terribly well. It's probably bigger than it looks on the camera. We have a TV, which helps to give information about studies sometimes. We use it as a bit of background noise as well. It just makes it more comfortable. We have a teddy bear as well that was donated by a member of the public, which we never found a home for. So he is a research teddy bear. Oh, excuse me. We have a kitchen, so it can provide refreshments, which is gratefully received by most of our participants. The kettle is certainly on most mornings, and our main clinical area here, as you can see. So we tried to set it up as close to some of the facilities that you'd see in a hospital as possible. We have an examination table, couch, which is electric, so easy to use. We've got all the emergency equipment that you'd expect in sort of clinical areas around the hospitals. So all the nurses that come from Nottingham, all the people who work in the hospitals are very familiar with how to use those. We haven't had to use anything yet, I'm grateful to say. We have facilities for storing drugs if we need to. So potentially we can do drug studies, and it's one of the things that we'd like to do this year, is provide therapy for people with exacerbations of their COPD. And at the other end, it's split into 3 areas. I ought to mention, without backing into the stand, that we have a toilet as well. It's a chemical toilet. It's not the glamorous part of the unit, but it's accessible, and we're glad that it's been provided. And this end of the unit was set up as more of a lab area, but we do use it fairly flexibly for patient interviews, consent, so that we can have more than one patient on the unit at one time. But it's a fairly good area for doing all sorts of blood manipulation if we need to. We've got facilities for storage of drugs in cold environments if we need to, and we've got freezers for freezing samples before transporting back to the hospital sites. And I'll hand back to Kate or Liz. Liz, thanks very much.
Thanks so much. I think it is me. So let's have a look. Thank you so much, and I'm really hoping that we see you at the next Oscars ceremony. I think you definitely deserve Academy Awards for that production. Thanks, Jack. So now we move on to my introduction to Professor Charlotte Bolton. Professor Charlotte Bolton works at the University of Nottingham. She's also a consultant in COPD at Nottingham University Hospitals NHS Trust. And she is the person that leads this research that we're going to talk about now. So over to you, Charlotte.
Thanks, Liz. And yes, I lead it, but I've got a fantastic team that deliver and drive and face a lot of the challenges that we've faced over the last year, such as understanding when the ice hits, keeping the water running, for example. But they've tolerated extremes of weather, but to make sure that it's all safe and all warm and as good as it can be for when people come on board. Can you put the next slide, please? So to set the scene, I'm aware that not everyone has a working experience, knows of people with COPD, but COPD is chronic obstructive pulmonary disease. So long-standing lung condition that causes narrowing of the breathing tubes. In the UK, we reckon there's at least 1.5 million people with COPD diagnosed. But we also reckon a quite shocking number, similar number of 1.5 million people haven't been diagnosed yet. I'll come on to some of the reasons behind that in a moment. If we take it down to a Nottinghamshire level, we're talking 12,000 people with COPD diagnosed. And again, a similar number, we reckon 12,000 people who have got COPD but haven't got that established diagnosis yet. Globally, it's a very common condition. And sadly, we need to raise the bar. We need to raise the game in terms of delivering better clinical awareness, diagnosis, management of COPD. It leads to a number of different symptoms that really can be quite limiting. Breathlessness on walking and activities of everyday living. It can cause a cough, and often that cough produces thick, purulent sputum, thick, sticky, green sputum that can be troublesome to clear and can make people prone to chest infections. The focus of this work has been around earlier detection of that condition that a person already has if they've got it. And earlier detection, it's really important when we're looking at that. Why do we want early detection? Are we just labelling people with another condition earlier for the sake of it? No, is the absolute clear answer there. Earlier detection of COPD in people at risk with symptoms gives us a better opportunity to offer input, to offer treatments, to offer therapies, and aim to slow any deterioration and ideally improve a lot of those symptoms. In order to make a diagnosis, we invite people at risk of COPD, and I'll come on to that in a moment, with symptoms as above, so breathlessness, cough, frequent chest infections, limited in what they can do. And then we do a breathing test, as one of my colleagues is demonstrating in the picture on the right-hand side. This is called spirometry, and that aims to confirm the diagnosis alongside the risk and the symptoms. Next slide, please. Sounds straightforward. There are several challenges. Challenges of identifying people at risk. We need to encourage them to come forward with their symptoms. It's human nature that if you become breathless doing an activity, rushing for the bus, walking quite a distance to the supermarket, human nature means that we often stop doing that activity and so don't necessarily immediately identify that symptom as being limiting. We need to encourage and ensure that people know that if they do come forward to be assessed, and they may or may not have COPD, but if they are diagnosed with COPD, there are ways to manage this. The other challenge, and what we hope to address with the mobile research unit, is if you're breathless, the last thing you want to do is to jump on 2 different buses or even drive to the car park, walk 15 minutes to get to the department at the hospital that you need to get to. You need something local and as accessible as possible. Again, if you're coming forward for assessment to see whether you've got a condition or not, you need something as more straightforward as possible. Spirometry is a straightforward breathing test, but actually, as all of us have been taught, the able hands of Paula, who I know has joined the call, it's extremely important to deliver it in a safe and efficient manner so that the results that we get from the breathing test are reliable and we can base a diagnosis on. And so all of the team on the unit have spent a considerable amount of time being trained up in the spirometry in order to establish and offer diagnostic breathing tests to the people that volunteer and take part. Then there are challenges with the system. Spirometry is absolutely crucial, but it requires clinic space. And whilst a lot of GP surgeries were doing it, there's clearly a lot of demand within primary care. And if spirometry is taking up one room, it's not allowing for the ever increasing number of patients presenting with acute illness. We had a little thing called the pandemic 5 years ago. I think someone said it was 5 years ago today it was declared. That stopped all breathing tests by nature of the fact it was a blowing test and there was fear that that might spread the virus. And therefore, for at least 3 years, if not longer, there were thousands of patients in the UK having symptoms, coming forward, but they literally could not have the breathing test and therefore could not be diagnosed. And one of the big Lung Foundation charities estimated that in 2020 to 21 alone, that was potentially 40,000 people. Inevitably, pandemic has settled and we now know more about the breathing tests and how to do them in a safe way so that they aren't passing on the virus. But inevitably, there's a massive backlog in doing the breathing tests, and we're trying to overcome that. And to me, an absolutely vital aspect that we're trying to deliver in this research study is to ensure that when a patient does get a diagnosis, they get information, well, they get the diagnosis at the same time, and they get some initial information about the condition to go away from that consult with. There may well be a couple of weeks for them to make a contact with the GP surgery to get information about inhalers or other medications, but at least our patients are going away from the appointment with some information armed with some advice to act on straight away. Next slide, please. So as you've seen, this is the mobile research unit. It is mobile, perhaps not quick park up and drive on to the next space. I sort of envisaged initially it would be a van that I'd be driving around and sort of pulling up in front of patients' houses, but it's a fantastic resource. It takes me back 20 years to when I was doing my higher degree. I was driving around Cardiff with a spirometer in my boot of the car, unloading it into a GP surgery, and at the end of the evening packaging it all back up again and moving on to another GP surgery. This is state of the art, delivering clinical research in a safe, clean, clinical environment with all of the backup equipment there as well. Next slide, please. So far, we've been to a number of different areas across Nottingham, and as we've referred to earlier, we're currently in Hucknall. We're hoping to go to Arnold. We have predominantly based ourselves in supermarket car parks, thinking that they were areas where people would tend to frequent to do their weekly shopping. We've tried to target supermarkets in housing populated areas, and we've tried to consider things like bus routes and predominantly invited people from that close vicinity where possible. There are some big gaps on this map, and there's lots of places we could go. There's also thousands of patients we're trying to reach. Next slide, please. One of the group of patients that we're trying to reach out to are people that have already been identified and taken part in an assessment called the Targeted Lung Health Check. The Targeted Lung Health Check, despite its name, is actually a screen, a CT screen for lung cancer. This NHS England check is inviting people aged 55 to 74 with a significant history of smoking, either in the past or currently, and doing a CT scan to see if they have a cancer unknown, or might have a lymph node or a nodule that needs monitoring or further investigation. The same people are at risk of COPD, but the CT scan, despite it saying lung health check, doesn't actually cover COPD. And so we have been inviting a number of people who've had the CT screen, who've had an all clear, because we don't want to interfere with anyone that has got any concerning shadows, masses on the CT scan. And we've been inviting them to come back to have a further assessment. Next slide, please. Quite a busy slide, but I'll take you through it step by step. If we start in the top left corner, the blue box here, the predominant way so far we've identified people who may be susceptible is people who've had a CT scan as part of this targeted lung health check. They've had the scan, they've waited a few weeks, they've got the report, and the report says, you're okay. They actually do a traffic light system, so it's a green report. It looks all right. There's nothing concerning, suspicious, or anything that warrants rapid investigation at the hospital. My clinical colleagues have then been inviting those people with a scan that's okay to take part in this study called CFind, particularly if they've got symptoms of breathlessness, cough, or limited walking. We have also been inviting and trying to open up the doors for other people who have smoked in the past and have got symptoms. So we're not completely blinkering to people, only people who've had a CT scan, but we started off predominantly the CT scanning people. We're now opening up the doors and we're trying to look at other communities. We invite people to take part in the study. It is a research study, and the main thing we're researching is actually having the assessment in this environment in a mobile clinic. If they agree, we book them appointments, we consent them for the research and also for the assessments. We ask quite a detailed information about the patient, and we ask some questionnaires about how the breathlessness is and how it impacts on a person. We do spirometry, and again, importantly, I feel, I'm biased, we do what's called diagnostic spirometry. So we give some bronchodilator, so a medication that opens up the airways as much as they possibly can be, and then we do the breathing test in that maximally improved state of the airways. With the team and the fantastic training, the team are then able to read the spirometry, put it together with the symptoms and the history from the patient, and if the spirometry looks like it's COPD, they will actually give the diagnosis there and then to the person. They will talk about smoking cessation if the person's still smoking. They will talk about self-management, they'll talk about vaccinations, they'll talk about keeping active, and will make a recommendation. I'm now looking at the purple area, to go and see the GP surgery in 2 or 3 weeks' time for ongoing support and to discuss if there's any role for inhalers. In addition, there is an optional aspect, which is we're trying to learn more about COPD. We're trying to see if there's even better measurements than spirometry. So we are asking for a blood sample and a nose swab, a bit like the COVID nose swab, so that we can actually try and pick up novel new biomarkers, novel measures in the blood that may give us more information about COPD, particularly in the earlier phases of the condition. And they all go off to the lab and have clever tests, which is what the picture in the bottom right-hand corner is. Next slide, please. So yeah, we're currently inviting people over the age of 40 who smoke or have smoked regularly for several years. I confess, I admit that smoking is not the only cause of COPD, but it's what we have to focus on in a research project. We have to try and define a sort of core group of people. And we're particularly looking for people with symptoms classical of COPD, so breathlessness, cough, breathlessness, walking. And then they may have had a CT scan as part of the lung cancer screening, or they may self-present to the unit, and they need to then give agreement and consent to take part. Next slide, please. To date, so we have assessed very close to 450 people at risk of COPD and with symptoms. 20% of them have got a new diagnosis of COPD, so close to 100 people have been given a new diagnosis of COPD. We've also seen some people who've had COPD already diagnosed but wanted a check, wanted an assessment. We've also been able to reassure an awful lot of people. The other 80% haven't got COPD. I've put yet. I'm hoping that if they stop smoking and try and reduce the risk and try and improve lifestyle characteristics, they won't develop COPD in the future. But we've been able to give a lot of reassurance. For those that smoke, we've given basic smoking cessation advice. We've given leaflets and documentation, whether or not they've got a new diagnosis of COPD. And then we've fed the information back to the GP. As Jack alluded to, we've actually started discussing with lots of community groups in the area too, from various summer festivals to community groups to different social groups. And as some on the call will know, myself and I know Ayushman will in the future, we've gone out to lots of different patient support groups again to try and understand the best ways forward of delivering and doing this work. Next slide, please. We ask people what they thought of the research. I'm really pleased to see that staff, because that's my view, but staff, Jack, Paula, Keba, Elizabeth, and the teams that have helped in the past have really been so supportive of people who are often quite nervous, quite anxious about what the tests are going to show, but are receptive to being given that information. They're given lots of results, they're given information, friendliness, professionalism have all been recognised. Importantly, convenience, locality have also been highlighted. We did ask what was the least useful aspect, and I haven't shown it, but the biggest thing there was nothing, which is good. Other comments we try to meet. I guess we haven't got all the cups of the flavours of coffee and tea and biscuits that some would love to have. Next slide, please. Importantly for me, this is a pilot. This is a learning exercise. We've still got lots more to learn. A year and a half into it, a year and a quarter into it, would like to know, have we got the reach right? The reach into the community right? Should we be inviting people at risk and with symptoms generally? Should we forget the specific focused attention on people who've had a CT scan? The length of the assessment has been a challenge. To have the consent, to have the information, to do the test, to get a diagnosis and be given information can be quite a long duration. But the alternative is that we do the test and we send it to the GP surgery, and then a person is none the wiser until they've had that assessment. It also relies on the GP surgery being able to interpret the results and give the information. We need to ensure that the GP surgery get the results in a timely manner to continue management. And we try and give a realistic time frame of 2 to 3 weeks for it to be sent out to the GP surgery, for it to be actioned, for it to be filed, and for, oh, can you go back? For them to speak to the person. And ultimately, and I don't have this question for this research study yet, does it improve the outcome for the people that we've diagnosed? Next slide, please. This has been a massive team effort. And there's a few people on the call will recognise themselves in some of these photos. We've had the community research team, we've had the respiratory team, we've had the university, we've had the NHS and the clinical research facility. Importantly, I've really valued the research volunteers represented on this call, I can see, in supporting the patient visits, but also in some of the community events that we've held, for example, at Forest Rec. We've had support from AstraZeneca, from Nottingham Forest Community Trust, from Evolve, which is a city centre initiative. I loved where they put the bus on the Morrison's sign. More reasons to shop at Morrison's, absolutely, you bet, because they very kindly gave us a supermarket space for free. And then we've had fantastic support from the Biomedical Research Centre, University and NHS. But it's the team that's delivered, and huge thanks to the patients and research volunteers. Next slide, please. This project is one of several. We're trying to learn new ways of reaching out to the public, to people with COPD. Very happy to forward on a copy of our latest newsletter with that email address. And importantly, and I know again there's people that are affiliated with Asthma Lung UK, for anyone that has symptoms, wants to find out further information about COPD clinically, wants to get further advice, then I highly recommend the Asthma and Lung UK website. Thank you.